Welcome to the People's Health Briefing, a component of the Trusted Voices campaign. I'm Dr. Noha Balata from Roots Community Health Center, reporting for the week of February 22nd, 2021. As health professionals rooted in Oakland, serving some of the people most vulnerable to getting and suffering from COVID-19, we are here to cut through the noise to give you information you can use to make choices that will keep you, your loved ones, and your community as safe as possible. The goal of the People's Health Briefing is to empower you with our best knowledge and thinking every Tuesday morning. Please submit your questions in the comments, by direct message, or by email to admin@rootsclinic.org. Now, we know that even though the pandemic is worldwide, the effects are very different depending on where you are. So we are here to give you up-to-date information about Alameda County and Oakland in particular. Alameda County now has over 79,000 cases and 1,200 COVID deaths. Here you can see daily case rates, hospitalization rates, and ICU hospitalization rates all continuing to come down. And this, of course, is good news, particularly considering that we are coming off of a severe wintertime spike, and that in the US alone, over 500,000 people have now died from COVID-19. And we are just now finally getting to a point here in Alameda County where our 14-day average case rates are coming down and are now a little below where we were in our summertime spike. So case rates are coming down. Are they going to continue to come down? Well, first we need to look at why they went up in the first place. And first we need to look at reopenings and gatherings. Just as a reminder, here in Alameda County, we've really only had 2 peaks. Now, other parts of the country and the world had earlier peaks in the spring, but because we sheltered in place early here in the Bay Area, we were able to flatten that curve and kind of have a long, flat curve initially. So we avoided that springtime spike. We had our first reopening on June 18th, and then shortly thereafter, we headed towards our summertime spike. I'm not saying that the reopening is the only reason for the spike, and we do not have studies to prove cause and effect. I'm just laying out a timeline here. Then in mid-July, cases began creeping up and continued to do so. And later in July, we were put on the state's monitoring list and had additional restrictions placed on us, and cases started to come back down. And the next significant reopening was in late October. After that, we began seeing another upslope right as we headed into the holidays, and it just kept on picking up steam after that. We saw a staggering amount of travel happening over those holidays, Thanksgiving, Christmas, New Year's, and cases just kept climbing and really didn't peak and start to head back down until around the second week of January. And thankfully, it has continued to keep coming down since then. But I will remind us that we remain in the purple tier, the most restrictive tier. And so that is still limiting the amount of activity that we believe may have contributed to both the summertime and wintertime spikes. The second reason why cases may have gone up and are now coming down could be due to what's called seasonality. And scientists have been speculating from the beginning of the pandemic about this, partly because we have experience with viruses that have seasonality like the flu. That's why we refer to flu season, which we know happens in the colder months where we know that cases will be on the rise. And this was one of the reasons why the wintertime peak of COVID was actually predicted ahead of time. A recent analysis published in Evolutionary Bioinformatics took a look at COVID-19 cases worldwide and showed a statistically significant correlation between temperature and features of the outbreak, like number of cases and number of deaths. They looked at correlations with temperature, with latitude, and found that indeed there is a correlation between the environment and disease spread, where the virus does spread more efficiently in areas associated with colder weather. All the reasons why have not been completely established yet, but there's a lot of data we can draw upon to understand this better. First is the virus itself. It doesn't seem to spread as easily in hot temperatures. COVID doesn't do well with sunlight, heat, or humidity. COVID thrives best where it's cold, dry, and out of direct sunlight. So when it's warm, humid, and sunny, the viral particles degrade more quickly, and therefore there just are not as many viral particles available circulating out there to cause infection. A second reason is our behavior. We tend to be indoors when it's cold, windows shut, poor ventilation and air circulation, and this creates more favorable conditions for the virus and for transmission if we are gathering indoors. Now, we all know that especially respiratory infections tend to happen more to us during the cold months. And this has been recognized probably forever, though we may not always have known the reasons why. But there's been some interesting research even before COVID showing that the cold weather weakens some of our immune system's first lines of defense in our nose and respiratory tract. So our own immune systems may not be as up to the task in the cold weather as in the warmer months. Also, in the wintertime, we are not making as much vitamin D. And I discussed vitamin D and COVID in great detail in the December 22nd People's Health Briefing. But we know that adequate vitamin D levels are critical for proper immune functioning, which is why we recommend supplementation. And this is even more true in the winter months when we are likely to have less sun exposure. Now, to be clear, it's not particularly great news if COVID-19 is seasonal, because that could mean that we deal with surges of some kind every year. So while we're certainly hopeful that we will get ahead of the virus with vaccination, even then it is possible that we could be dealing with COVID season like we do with flu season. But the good news about that is that even if it's seasonal and every winter we see some type of increase, that hopefully means that maybe in spring and summer it decreases, which gives us time to help with planning. Maybe we can catch a little break to give us time to prepare like we do every year with the flu. So far, since the onset of the pandemic, we have really not been able to catch a break or get ahead. So we can definitely always hope for that. A third reason cases may be coming down, and this is a not so optimistic reason, is that testing rates are coming down. You can see here Alameda County total test rates, and this is a 7-day rolling average, are coming down pretty significantly here since late January. And certainly we are seeing a decrease at our own testing site as well. Through this pandemic, we've experienced everything from lines all the way around the block to no lines at all. And currently we are seeing that testing has gone down across the county and actually across the nation. This time, unlike last spring, this seems to be tied directly to behavior and not access. So in other words, it's not that any test sites have been closed or that testing is less available. It's that people are choosing to get tested less. Now, why is that? Well, it's difficult to say. I certainly hope that it's because fewer people have been exposed. Fewer people are getting that phone call saying they better get tested, and fewer people are getting symptoms because fewer people are getting COVID-19. And this is at least partly the case. We're fairly certain because we also see that hospitalizations and death rates are coming down as well. And we know that those things are not dependent on testing, right? If COVID takes you to the hospital, it takes you there whether or not you had gotten a test before you went. Nevertheless, when testing rates come down like this, we have to remain concerned that this means we are missing cases or that we may not have the entire picture and that cases are coming down just because people are not getting tested. Now, we do not believe that the decrease in cases has anything to do with herd immunity. And I need to make this very clear because that would be great if that were the case. I really wish that was the case, but we just do not have any reason to think that that is the case. So with some quick kind of back of the napkin calculations, I'm not saying you can take this to the bank, but you can just bear with me. We have got 79,000 people who've had confirmed COVID cases. And unfortunately, of those, 1,200 died. We have another 80,000 in the county who have received both doses of the vaccine. So if you add the people who have recovered from COVID 19 plus the people who are fully vaccinated, we are assuming that that is a group of people who have some fairly decent immunity. And that is still less than 10% of the population of the county. So we still have a ways to go. Now, over 200,000 people have received their first dose of the vaccine. So that means that we are on our way. But at this point, I just don't think that we can attribute the decrease in cases to vaccination or any kind of herd immunity. So this leads us to the question, will cases come back up? Will we have another spike? And this is very difficult to know, but it depends primarily on a few things. One is the reopening plan. Once reopening starts to happen, we do expect cases to increase yet again. And it is reasonable to expect that, at least until we get to herd immunity. So, when will cases come back up? That likely depends on when reopening happens, how quickly it happens, and then how everyone is going to act. I'm trying to stay hopeful about that we've learned our lessons from our prior spikes, but I don't know. This will remain to be seen. And it's not just about reopening, it's people's behavior in general. As we continue through this, are we continuing to mask and distance? Are we being mindful of maintaining good ventilation and avoiding crowding? Are we sheltering in as much as we can whenever we can, but only with members of our own household? There's no question that our behavior and continuing to follow the guidelines can help keep cases from bouncing back up. And last, but definitely not least, are the dreaded variants. And I reviewed variants in detail at the February 2nd People's Health Briefing. So if you're interested in that, please check it out. Now, since then, the South African variant has unfortunately been isolated here in the Bay Area, both in Alameda and Santa Clara counties. But the name of the game with the variants is the same as with the dominant strain. And the bottom line is that the extent to which we can get ahead of it with vaccination is going to directly impact how readily the variant can spread. So if we can reach herd immunity more quickly than the variant can take hold, then we will dramatically limit the amount that variant can continue to cause a spike, another spike. So we need to continue efforts to vaccinate in order to stop that rampant spread and to keep the more contagious variant from taking over. Now, I know many of you are waiting your turn for the vaccine, and many have expressed frustration about not knowing when you will become eligible or when the vaccine will be made available to you. And the fact of the matter is that we do not have enough vaccine for everyone at the moment, which is why we are all having to struggle through the tiers and the phases and the prioritizing based on principles that we may or may not agree with. But as production and distribution continues, we will get more and more people protected. And as always, we are particularly concerned about those who are at risk of doing poorly if they catch COVID. And unfortunately, not all of those people are in the eligible tiers yet for vaccine. So, for instance, if you are 60 years old with diabetes and you are not in one of the eligible professions, then you are not yet eligible for the vaccine. So, what do we do in the meantime? Well, I know you have all heard the guidance a million times about masking, distancing, testing, and isolating. But what about treatment? Are there treatment options available? Well, up to now, we've said that supportive care is it until and unless you are sick enough to go to the hospital. What is supportive care? That is basically staying at home, drinking plenty of liquids, maybe taking ibuprofen or Tylenol and getting some rest. The same stuff you do when you get a cold or the flu. It is unfortunate that this far into the pandemic, we still have relatively few treatment options. And this is in part because most of the focus really was on developing the vaccine, which was a tremendous achievement. But I do believe that the study of therapeutics has suffered as a result. Here you can see the recommended pharmacological management of patients with COVID-19 based on disease severity. And it's a pretty short list of treatments. And as you can see, all but one of them are for the inpatient setting. So, in other words, they are not appropriate for you until you are sick enough to actually be admitted to the hospital. And this short list of recommended inpatient treatments basically includes oxygen, steroids, and the antiviral drug remdesivir. But there is one treatment that is recommended in an outpatient setting, and that is monoclonal antibodies. You may recall that Donald Trump received this treatment when he had COVID-19, and it is a treatment that is shown to decrease the rate of hospitalization and death. The way it works, and it's the Y shapes shown here, is that it clicks right onto the spike protein of SARS-CoV-2, which keeps the spike protein from being able to then click onto our cells. So if the virus can't bind to our cells, it can't get in and it can't wreak its usual havoc on our bodies. Monoclonal antibodies were approved for emergency use back in November, but sadly, it is going underutilized. It is literally sitting on shelves in hospitals, and I will talk a little bit about why that is in a moment. But first, who is eligible? Well, monoclonal antibodies are intended for people who are not hospitalized, but who are at risk of progressing to severe COVID and or hospitalization. So to be eligible, you must meet at least one of the following criteria. You must be 65 years of age or older, or 55 years of age and older with heart disease, hypertension, or chronic respiratory disease. Any age with diabetes, or a body mass index of greater than 35, chronic kidney disease, a condition that caused you to be immunosuppressed, or medications that cause you to be immunosuppressed. And lastly, 12 to 17-year-olds with certain conditions like obesity, sickle cell, and even moderate to severe asthma that requires daily medications for control. Now, the challenge with monoclonal antibodies is how it has to be given, which is by a infusion. And so this is an IV treatment. It's a 1-hour infusion followed by 1 hour of observation. Also, monoclonal antibodies must be given to confirmed COVID positive patient within 10 days of the onset of symptoms. So this requires that you actually get tested. It's confirmed that you have COVID, and you get the treatment as soon as possible after that, but not more than 10 days after the onset of symptoms. This is another good reason why, if you have symptoms, particularly if you're in one of these high-risk categories, that you do get tested right away and isolate. I'm not going to go too deep into the data on monoclonal antibodies today, but I really just wanted everyone to be aware of it. The studies that allowed for emergency use were small, but they clearly demonstrated safety. And our experience now, in addition to those studies, is continuing to show that not only is it safe, but it is decreasing hospitalization and death significantly in these high-risk groups. Now, remember that I said it's not recommended when you are sick enough to be in the hospital, and that you need to start it within 10 days of symptoms. So it really is a timing thing. Timing is really of the essence. If you or someone you know contracts COVID and is in the high-risk category, please inquire about monoclonal antibody treatment. Now, there is a bit of a challenge here, which is that it may not be so easy to find. Why? Because, as I mentioned, this is technically an outpatient treatment, but it is a 2-hour process, and not that many places are really equipped to administer it. We are keeping a close eye on this and even advocating for additional sites to open up, and we will have more to report in future briefings. But this can be life-saving. It can avoid hospitalization, and it is imperative that everyone who is eligible get access to this treatment, not only to improve that person's outcomes, but also for the population at large, because as we all know, exceeding hospital capacity is the most feared disaster that many of our hospitals across the country actually did experience. So the fact that there is a treatment that could potentially reduce this burden on our hospitals and improve outcomes is actually very important. Now, the federal government, the Department of Health and Human Services, has launched a locator where you can type in your zip code to see where this treatment is offered near you. That if you do a Google search, monoclonal antibody locator, that site will come right up and you can check it out. You can also contact your provider or your health plan if you think you may qualify. This treatment is being distributed free right now by the federal government and should be accessible to everyone. Now, hopefully, you will not need this because you'll continue doing what we all know we need to do, and that is to mask, distance, ventilate, keep those windows open. If you are exposed or you have symptoms, get tested, isolate, and contact those who you have been around to let them know that they should do the same. Don't share your air, mask up, space out, always protect your elders and those with underlying conditions. If you think you are exposed, do not go to work, do not gather, isolate yourself, get tested in 5 days. If you have symptoms, get tested right away. Continue to isolate until you get your results. Take a multivitamin supplement and additional vitamin D supplementation. This concludes today's People's Health Briefing. Thank you for joining us. Please tune in next Tuesday at 10 a.m.